Well, good morning, good afternoon, good evening, and welcome to this World Day of Regional Anaesthesia and Pain Medicine being organised by Professor Nuala Lucas, Sebastian Block, and our President of ESRA, Eleni Mocha. My name's Alan MacFarlane. I'm a consultant anaesthetist in Glasgow in Scotland, and I'm also on the ESRA board. And I've been asked to talk to you briefly about NAP8. And NAP8 is studying major complications of regional anaesthesia and other perioperative nerve injuries, and it's being run by the Royal College of Anaesthetists in the United Kingdom. And what I'm going to talk about are what are the national audit projects, particularly for those of you who don't work in the UK, why we're studying this topic in NAP8. We'll talk about the methodology and progress so far, as well as some of the potential difficulties. So what are the national audit projects? Well, they're classified technically not as research, but instead as audit or a service evaluation. And what they're designed to do is to collect data on rare major anaesthetic complications that we can't study in randomised controlled trials because we don't have large enough numbers because these complications are so rare. And we're very lucky in the UK because they only occur every 3 to 4 years, and the vast majority of the UK anaesthetists all take part and help us out collecting this data. And to keep it simple to explain how they work, then what happens is there's a very short intensive activity survey. So for example, for 1 week, we collect all anaesthetics that take place and all the anaesthetists enter the data from those anaesthetics into a national database. We then take that data, we multiply it by 52, and that gives us the number of cases that have been done in 1 year. For 1 year then, what we also do is we collect a specific complication and it's entered into a national registry or a national database. So NAP4 looked at airway complications, NAP5 looked at accidental awareness, NAP6 looked at anaphylaxis, NAP7 looked at cardiac arrest. And what it does is it takes the 1 year complication data, it's got the number of them, you divide that by the number of anaesthetics that have been extrapolated up to 1 year. You've got your numerator, your denominator, and that gives you the incidence of these rare anaesthetic complications. And you've also got some data that lets you potentially analyse these events and look for some associated factors which might influence risk. So why are we studying regional anaesthesia and NAP8? Well, certainly at the minute, as we all know, regional anaesthesia is undergoing a little bit of a renaissance in the UK. It's now got its own domain in the Royal College of Anaesthetists curriculum. We've got evidence that our residents, a lot of them want to incorporate regional anaesthesia into their consultant jobs. But as with general anaesthesia, we know that regional anaesthesia is not without complications. So these complications are rare, but this is evidence from litigation related to anaesthesia in England, and in the past 10 years, the number of claims due to peripheral nerve blocks has doubled. And if you're a patient coming for your operation, then it's our job to help you choose what is the best anaesthetic for you as a patient and for that specific operation. And in order to do that, we need data about these rare complications. Some of you might remember the third national audit project was published in 2009, but the data for that was collected almost 20 years ago, and we know from the last NAP that was published, NAP7, that patients over the last 20 years have become older, they've become sicker, they've got higher BMI, they've got more comorbidities, and there's new drugs that now exist that weren't available back in the time that NAP3 was studied. So new anticoagulants and new antiplatelet agents, and all of these increase the potential risk. So central and reaxial blocks will be covered in NAP8. NAP8 will also, however, look at peripheral nerve blocks as well. And that's where I think there's a big gap in the market for evidence. This is a nice review by Rakesh Sundikopam and his colleagues in RAPM in 2023, and they combined the data from over 90 studies, and they determined that the rate of permanent nerve injury after a peripheral nerve block was around about 1 in 3,000. But we know from a lot of the studies included that many of the patients weren't adequately followed up for a long enough time to really know if that nerve injury was permanent. And they also didn't, in a lot of the studies, adequately investigate if that complication was definitely due to the block or if it was due to surgery. And indeed, if you come for an operation, it's not just regional anaesthesia that is the source of nerve injury. You can have a direct surgical nerve injury, or you can have injury from positioning or from a tourniquet or from spinal cord ischemia, for example, all of which are very rare. And again, we know that the data for permanent peripheral nerve injury following a general anaesthetic is dated. A lot of the studies that you see in this nice review here by David Hewson in Nottingham, who's on the RAUK board, a lot of the studies are 20, 30, 40 years old. So again, this is something that we need to update the literature on, and it's something we'll be studying in NAP8. These are just some pictures of one of my favourite places in Scotland. This is the island of Arran, where I go regularly to get away from things. So in terms of the methodology and progress, this is what we're looking at in NAP8. So it's all patients who are under the care of an anaesthetist, if they've had a general anaesthetic, a regional anaesthetic, sedation, or monitored anaesthesia care. And we're looking for patients who suffered harm as a result of either regional anaesthesia, so a peripheral nerve block, or a central neurexual block, as I've already discussed, but also surgical local anaesthetic infiltration. Or we're looking for patients who suffered major harm not due to regional anaesthesia, so a perioperative nerve injury that's unlikely to be directly related to the operative procedure. So by that I mean compression, positioning, or a tourniquet, not direct surgical damage. We'll be looking at adults and children. We'll be looking at blocks in intensive care. We'll be looking at all the pain blocks, and we'll be looking at blocks done by anaesthetists in the emergency department. The Royal College of Emergency Medicine will run a separate project looking at all the blocks done by the emergency physicians. And this is the timeline of the project. So we started in October 2024. There's a big team involved who are helping out. It's certainly not just me who's doing all the work. And this is the timeline of where we're at. So we've been working for the last year in the methodology, building the surveys up that I'm going to talk about in a minute. And that jigsaw is pretty much complete. As I say, it's not just me that's doing it. There's a big variety of stakeholders who are involved, not just anaesthetists, but we've got patients, neurologists, neurosurgeons, peripheral nerve surgeons, clinical neurophysiologists, nurses, a variety of people. And it's not just the UK that are taking part this time, but Brian O'Donnell in Ireland and Aoife Driscoll, his fellow, are going to be running it in Ireland as well. Just to quickly say that it costs a lot of money to run the NAP, and I just want to thank Ezra, who are contributing some of the money towards running this project. As I've said, it's not research, so we technically don't get research approval through an ethics committee, but we still have to go through the appropriate channels to make sure that we are allowed to do this project in the UK. So that's a big piece of work, which I won't go into in any significant detail. And just to outline in a little bit more detail, the three main stages of the national audit projects. It starts off with baseline surveys, and we're actually running these baseline surveys at the minute. We've already got over 7,000 responses. And what these baseline surveys are, they go out to every anaesthetist in the UK and they ask certain questions about regional anaesthesia practice and their experience of complications. We also send a baseline survey out to each department, again asking them specific questions. And what we're looking for really are specific information about aspects of regional anaesthesia practice, barriers to regional anaesthesia, consent, information provision, follow-up, service provision and training, and that together will build up a picture of regional anaesthesia practice in the UK. But the main component is what I've touched on already, is the activity survey and the case registry. So the activity survey we're hoping to run in June 2026, and as I already mentioned, that'll be a 7-day survey of all sites where we want all the data put into this database. That'll be multiplied up to give us our denominator data. And then what we will have after that is our 1-year case registry. And that's that time period where over 1 year we want all complications entered into this national database, which will help let us calculate the incidence of all these rare complications. When the complication is submitted, it will be looked at by a multidisciplinary team, so not just anaesthetists, but as I've mentioned, neurosurgeons and peripheral nerve surgeons and neurologists, and we will try to determine, based on the data included, whether that is definitely due to the block or not. What we also have built in is a 6-month follow-up period, and after 6 months, if the nerve injury is still present, we will determine that as being a permanent nerve injury. As I've already mentioned, we'll have the data from the activity survey. You combine that with the case registry data, and that will give us the number of the regional anaesthesia complications, or the incidence, sorry, of these regional anaesthesia complications. This is the shortened list of all the complications that we are looking for, so all the usual things that you would expect as the major complications of regional anaesthesia. But it's not going to be straightforward, and I think one of the main difficulties will be picking up some of the complications. All these ones here in green you can see, like wrong root error, wrong-sided block, or local anaesthetic toxicity, or pneumothorax. They will almost certainly happen when the anaesthetist is present. Not always, but most of the time. Conversely, however, permanent nerve injury is often not going to present the anaesthetist, but instead it's going to present to the surgeons or physiotherapists or pain teams or at the neurology clinics or even to the medical legal teams. And so we have a system in place to try and get all these people involved to make sure that any case that gets presented to these teams gets fed back into our NAP8 database. So as I say, this is a summary of where we're at. We're hoping that the whole process will finish by round about July or September 2027, and it's really going to be 2028 before we get all the results analysed and disseminated. So that's where we're at with NAP8. I think it's quite exciting. As I say, we've just started the process. We've got all the anaesthetists in the UK involved, and it's going to be a little bit of time before we get to the stage, before we get the results. This is when I found out I was running NAP. It was just on my 50th birthday. It was a good birthday present. This is what ChatGPT says I'm going to look at by the end of these 4 years, but I'm hoping it's not going to be quite as bad. So just to summarise at the end, NAP8 is going to look at central nerve blocks, peripheral nerve blocks, and perioperative peripheral nerve and spinal cord injury. So it's a big topic. We'll have the largest peripheral nerve block dataset in the world. We've already launched, and we're hoping to launch the case registry early 2026, and the results will hopefully be with you in 2028. There's lots more information at the QR code here, and just want to thank everyone on the slide here who's involved and who's part of the team helping us run this project. Thank you.